Mental disorders are classified to Chapter 5 of the ICD9 Ch. Psychiatrists ordinarily state diagnoses in accordance with nomenclature used in the Diagnostic and Statistical Manual of Mental Disorders, or DSM, which is published by the American Psychiatric Association. Most of the DSM codes are the same as the ones used in ICD-9, but the terminology may be somewhat different. Psychiatrists, when diagnosing or stating diagnoses, often refer to the list as Axis 1 or 5. Axis 1 are clinical disorders. These include disorders diagnosed in infancy, childhood, or adolescence, including autism and ADHD, may include delirium, dementia, or other cognitive disorders such as dementia or Alzheimer's disease, mental disorders due to a general medical condition, substance-related disorders such as drug or alcohol, schizophrenia or other psychotic disorders, mood disorders such as depression or bipolar, anxiety disorders, somatoform disorders such as conversion disorders or hypochondriosis, sexual and gender identity disorders, eating disorders such as anorexia and bulimia, sleep disorders such as insomnia or sleep tremors, impulse control disorders such as kleptomania or intermittent explosive disorders, and adjustment disorders. Axis 2 are personality disorders and mental retardation, such as paranoid personality disorder, borderline personality disorder, an antisocial personality disorder, and a dependent personality disorder, along with mental retardation. Axis 3 are general medical conditions, which include concerns that may have a bearing on understanding the client's mental disorder or in the management of the client's mental disorder. Axis 4 are psychosocial and environmental problems, such as problems with the primary support group, as would occur in divorce, abuse, a birth, or a death. Problems related to the social environment, such as retirement, living alone, or having problems with friendships. Educational problems, such as illiteracy, academic problems, and conflicts with teachers. Occupational problems, such as unemployment, difficult work conditions, job dissatisfactions. Housing problems, such as homelessness, unsafe neighborhood, or problems with neighbors. Economic problems such as poverty and insufficient finances. Problems with access to healthcare services such as inadequate healthcare or having problems with transportation to healthcare, and includes health insurance problems. Problems related to interaction of the legal system, including arrest, incarceration, or even being a victim of a crime. And other psychosocial and environmental problems, such as those that occur in disasters or problems with healthcare providers. Axis 5 is a global assessment of functioning. This is a number from 1 to 100 that reflects the caregiver's judgment of the overall level of functioning. Organic brain syndrome is an older general term used to describe decreased mental function due to a medical condition. It is not a psychiatric illness. In general, the syndrome causes agitation, confusion, long-term loss of brain function known as dementia, or maybe severe short-term loss of brain function known as delirium. It may be acute and reversible, or chronic and irreversible. Organic anxiety syndrome is a psychosis characterized by clinically significant anxiety and is generally considered to be the physiological effect of a medical condition. To code this, you would code first the general condition and then an additional code of 293.84 to show anxiety disorder and conditions elsewhere classified. When the provider documents dementia without any other specification, then the default code would be subcategory 294.2, with a fifth digit indicating the with or without behavioral disturbances. behaviors can include aggressiveness, combativeness, and violence. Code 294.1 is used to show dementia due to a physiological effect of a general medical condition. An example is Alzheimer's dementia. In this situation, you would code first the Alzheimer's code, since it is the physical condition, and an additional code of 294.1 for the dementia. There is a difference in the descriptions between code 294.2, which is unspecified dementia, and 294.1, which is dementia in a condition classified elsewhere, so you got to be very careful. If a patient has a tendency to wander off, the facility may expect you to code V40.31, wandering in diseases classified elsewhere. And this can be used with code 294.1 or 294.2. Alzheimer's disease is a progressive atrophy including the degeneration of nerve cells. It includes mental changes that range from subtle intellectual impairment to dementia with loss of cognitive functions and failure of memory. Dementia is not automatically considered inherent in Alzheimer's, so if an individual has Alzheimer's and dementia, you need two codes as shown above. An altered level of consciousness not associated with delirium or with another condition is classified to category 780.0. The fifth digit indicates coma, transient alteration of awareness, or a persistent vegetative state. Code 780.9 is assigned for other alternate mental states such as stupor. Code 780.97 is assigned for an altered mental state or change in mental status with an unknown etiology. If the condition causing the change in mental state is known, you do not code 780.97. You should code that underlying condition. Schizophrenia requires you to pay close attention to the fourth and the fifth digits. The fourth digit indicates the type of schizophrenia, while the fifth digit classification is used to indicate the course of the illness. It is very important that you use the physician's statement to identify which fifth digit you should use. Affective disorders are common mental disorders characterized by mood disturbance. Major depressive disorders are classified as episodic mood disorders under category 296. Code 311 is assigned for non-psychiatric depressive disorders. Patients diagnosed as suffering from a major affective disorder are classified according to the type of symptoms they exhibit. Patients who experience sadness and withdrawal and loss of interest in social activities or other aspects of life are classified as major depressive disorders. Patients who exhibit symptoms of hypomania, rapid speech, flight of ideas, grandiosity, or poor judgment are classified as bipolar or manic disorders. Bipolar disorders are where patients experience cyclic or recurring mood changes that result in periods of severe depression alternating with extreme elation that are beyond the normal range of mood swings. The fifth digit category of 1 through 6 are assigned only when documentation of severity is included in the medical record. There are a group of 9 non-psychiatric mental disorders that include personality disorders and other 9 non-psychiatric mental disorders. And these are assigned to categories 300 to 316. And you'll see them to include anxiety states, alcohol and drug dependence and abuse, adjustment to stress, and certain physiological disorders. There are 2 categories for coding transient reactions to mental or physical stress. Category 308 classifies acute reaction to stress, while Category 309 is chronic reaction to stress. The fourth digit of this category is the nature of the reaction, such as anxiety or depression. Category 306 classifies physiological malfunction arising from mental factors, with the fourth digit indicating the body system involved. For the most part, the fourth digit code includes the associated symptom, and there is no need to assign an additional code. Category 316 classifies psychic factors associated with diseases classified elsewhere. Typical conditions include asthma, ulcerative colitis, and dermatitis. If such a condition is considered to be psychogenic in origin, you would code 316 first, followed by the code for the associated condition. Category 307 includes codes for a variety of special symptoms and syndromes of non-organic origin, such as tics or non-specific organic sleep disorders. You will see eating disorders such as bulimia nervosa, coded to 307.51, and anorexic nervosa, 307.1, are included in this category. Weight loss may be so severe in these instances that it leads to malnutrition, so code 261 for nutritional maramusis must be assigned as an additional code to fully describe the severity of the patient's condition. Although the terms abuse and dependence may be used interchangeably in certain treatment programs, they are actually very different conditions and are classified differently within ICD9 Ch. The fifth digit represents the pattern of use. Do not attempt to apply these digits without documentation of pattern of use in the medical record. Such documentation should come from the provider. Remember, that's your physician or a qualified healthcare practitioner who is legally accountable for establishing the diagnosis. The designation of pattern requires clinical judgment. You can assign a fifth digit of a 0 when the documentation is not specified or is unclear. Code 303.0 for alcohol dependence syndrome, acute alcoholic intoxication, is assigned when a patient who is dependent on alcohol presents for care in a state of acute intoxication. 303.9 is used when the patient presents not currently intoxicated but is entering for treatment, like a rehab program. Alcoholism, by definition, is a chronic condition. When the diagnosis is stated as acute and chronic alcoholism, code 303.0 covers both conditions. Although there is a code for history of alcoholism, V11.3, it is very rare for a patient with alcoholism to experience complete recovery. Alcoholism in remission is ordinarily the code that is assigned. Alcohol abuse is classified to code 305.0, alcohol abuse. This code is also assigned for a diagnosis of simple drunkenness. Category 304 for drug dependence uses a fourth digit to indicate the class of drugs involved. Certain codes include a combination of drugs. In particular, 304.7 is assigned when an opioid drug is involved with other drugs, or code 304.8 when no opioid drug is present. Non-dependent abuse drugs is classified to category 305, with the fourth digit indicating the drug involved. For both alcohol and drug dependence and abuse, that fifth digit indicates the pattern of use. Mental disorders related to alcohol use are classified to category 291 for alcohol-induced mental disorders. Three substance codes, 291.0, 291.3, and 291.81 are provided for alcoholic withdrawal. Only one of these codes should be assigned, with code 291.0 taking precedence over the others, and 291.3 taking precedence over 291.81. And you'll see this mentioned in the exclusion notes in the tabular index. Fifth digits have been added to subcategory 291.8 to provide separate codes for withdrawal, 291.81, and alcohol anxiety and alcohol mood, going to 291.89. Mental disorders related to drug use are classified to category 292, drug-induced mental disorders. Other mental disorders due to drug dependence or abuse are classified to category 292.1 to the 292.9 series. A code should be assigned for the differentiation of dependence or abuse. The designation of the principal diagnosis is dependent on the circumstances of admission, and you must follow the guidelines definitions. So let's take a look. When a patient is admitted with a diagnosis of a substance-related psychosis, you would sequence the psychosis first, followed by the alcohol or drug dependence or drug and alcohol abuse codes. When a patient is admitted for the purpose of detoxification or rehab or both, and there is no indication of withdrawal or other psychiatric symptoms, you would sequence the substance abuse or dependence code as the principal diagnosis. When a patient is admitted for detox or rehab for both drug and alcohol abuse or dependence, and both are equally treated, you may assign either condition as the principal diagnosis. When a patient with a substance abuse or dependence is admitted for treatment or evaluation of a physical complaint related to the substance abuse, follow the directions in the index for conditions described as alcoholic or due to drugs. Sequence the physical condition first, followed by the code for abuse or dependence. When a patient with a diagnosis of alcohol or drug abuse or dependence is admitted because of an unrelated condition, you would follow the usual guidelines for selecting a principal diagnosis. Detoxification is the management of withdrawal symptoms for a patient who is physically dependent on alcohol or drugs. If the medical record documents detoxification as being carried out, the code can be assigned even when no medications are actually administered. Rehab is a structured program carried out with the goal of establishing strict control on drinking and drug use. When the patient with a drug dependence is on medications for detox or maintenance programs to prevent withdrawal symptoms, such as methadone maintenance for opioid dependence, the appropriate code for the drug dependence should be assigned rather than a code of V58.69 for long-term use of other drugs. A code from rehab therapy is assigned for a patient who begins a program even when it's not completed. Category V57, care involving use of rehab procedures, is used for physical rehab only and is not assigned for alcohol or drug rehab programs. Detox and rehab for patients found with drug abuse or dependence is coded as follows: the 964.6 subcategories. And then treatments for drug abuse or dependence is coded to 964 as shown on the slide. Many patients exhibit maladaptive use of both alcohol and drugs, and combined therapy may be used for these patients. So there's codes to show the combination of drug and alcohol rehab or drug and alcohol detoxification, and then 94.69 shows combined alcohol rehab and detoxification. It is also possible to provide detoxification for either drugs or alcohol or both, and so you would code them as shown here. Psychiatric therapy also includes lithium therapy, play therapy, group therapy, and electroconvulsive therapy.